18 years, poorly compliant male came to me with the complaint of decrease in vision for last 1 month, and he gave history of blunt trauma with cricket ball 2 months back, followed by a decrease in vision, which resolved in 1 week time, and it was all because of hypema as per the previous record, and which improved with medical management. And when he came to me, his vision was actually finger count 1 feet with intraocular pressure of 6 millimeter only. Cornea was showing mild decimate fold, and anterior chamber depth was within normal limit. There was cortical cataract along with posterior segment was not very much adequately visualized, but the indirect ophthalmoscope did show some disc hyperemia with blurred disc margin, and it looked like retina was attached. But to confirm whether there was retinal detachment or not, we did the ultrasound, and there was elevation of the disc because of the disc edema, and there was choroidal detachment, thickening of the ciliochoroidal layer without any retinal attachment. But what was most important was the gonioscopy, and it showed there was posterior and peripheral anterior synechia inferiorly with CD cleft from 5 to 8 o'clock position, and the visualization was little difficult. This is the video of that same gonioscopy. See, this was, yeah. You can see the decimate fold there, and it was difficult to do the gonioscopy, but somehow the CD cleft was visible. I could manage to do the gonioscopy with the JAS 4 mirror. You can see very well the CD cleft. See here. So what next? Just to confirm, we can do UBM or we can do the anterior segment OCT. UBM was not available at that point of time, so we did the anterior segment OCT. You can very well see here the fluid in another view. What are the treatment options for me? It was to reduce the anti-inflammatory which was there, just to induce the inflammation or do the direct closure. So I stopped the steroid, started on cycloplegic, and when it did not improve, I did the photocoagulation, and with the last one which I did was the putting CTR in the sulcus with cataract surgery. So this was the sequence of event which I took upon just to control that, but patient did not improve with the topical medications or stopping the steroid. So the patient reported after 2 weeks, still there was no improvement and cataract had increased. So I thought of doing the photocoagulation, and you can see the photocoagulation mark here. 2 weeks later, again the status was not very much improving. So what I decided that I advised the patient to undergo cataract surgery along with the CTR implantation in the sulcus, and if not, then to go for the cyclopexy. So after the surgery, the vision improved in 3 days time itself, and the IOP started rising, and I could see there was some mild disc edema with macular fold, and 2 weeks time vision improved to 6/9. You can see the disc picture here, and subsequently the SOCT also showing improvement in 2 weeks time itself. So coming to the discussion, it is basically the cyclodialysis cleft is the separation of the ciliary muscles from the scleral spur, forming a direct connection between the anterior chamber and the suprachoroidal space. And confirmatory is the gonioscopy. If it is not possible to do the gonioscopy, then we can do the UVM anterior segment OCT. And now there are various management strategies for management. What I adopted was the photocoagulation and internal sulcus with haptic of the PMMA lens and CTR. So my case was, I think was SSOT, anterior segment OCT was very much helpful in delineating the extent of the CD along with the gonioscopy, and photocoagulation helped me, and cataract surgery with CTR really helped. So I did not need any cyclopexy treatment for this patient. Thank you. It's always better to intervene before 3 months, because there will be permanent change in the macula. But if you see that the pressure is not rising by any means, then I think considering everything, like patient had cataract also, so you have to manage the cataract also. So in that case, we have to intervene early also. And this patient was non-compliant. He was actually a mazdoor, a laborer in Gujarat. So he was very much कि मुझे जाना है जाना करके. That's why I took little early step also. गुजरात नहीं, वो बिहार के सारे उधर ही जाकर काम करते हैं.